Good evening and thank you everyone for joining us today. I am Saxena along with my colleague Dr. Deepika Chabra from Medical Services. On behalf of Jagsonpal Pharmaceuticals Limited Pharma Division would like to extend warm welcome to this fourth episode of SAFOMS Webinar Series Quality of Life Issues on MRS with topic How Sexuality in Midlife Impact the Quality of Life of Midlife Women. This web series organized by SAFOMS with technical partner SMLM and Jagsonpal Pharma Ltd, the makers of LycoRed, Verena and Divatrone. Jagsonpal Pharma offers to you LycoRed soft gel, which is found to be very useful to correct the nutritional deficiencies. It contains lycopene, served to enhance the general health and well-being. A warm and hearty welcome to all the esteemed faculties and the attendees. Dear attendees, if you have any questions, suggestions, clarifications, please post it on the Q&A box or chat box. We shall also enable the audio of attendees to speak up and make this webinar more interactive. So please raise your hand if you want to speak up. Please note this webinar is streaming live on Facebook and the link is already shared in the chat box for you to please share with your groups, WhatsApp groups. To refer this webinar recording in the future, please visit our YouTube channel, Jagsonpal Medical Insights. Now we introduce Dr. Maninder Ahuja, the convener of this webinar series. Dr. Maninder Ahuja, ma'am, a progressive, thought-provoking leader, Vice President SAFOMS, Founder President of SLML, Past President IMS, executive member of many societies. She is Editor-in-Chief, Journal of Midlife Health. She has been felicitated with many awards and has many publications and research papers. Now I request Madam to kindly initiate this proceedings.
Good evening, everybody. It's an honor and it's a privilege to organize the webinar series for under presidentship of our Dr. Rohana Haththotuwa, who is always gracing the occasion despite his busy schedule. And I think he does not need any introduction because he's there in all the organizations, medical organizations of the Sri Lanka and internationally at the SAFOMS and the SAFOG level and Secretary General of FOGSI also. So welcome to you, Dr. Rohana Haththotuwa, to this series. And please, we'll request you to say a few words and then we'll introduce our chairpersons later on.
Okay. Thank you, Maninder, for giving me this opportunity. So first of all, I must once again thank Maninder for this great effort of us organizing this series of webinars through SAFOMS. And they have been very successful and very informative. And she has been selecting different areas in each of these webinars. So today's topic which she has selected is on the sexuality in midlife. That is also one area which is very rarely, not less discussed and talked about. And our knowledge is also quite limited. And it is, I mean, there are so many in midlife who need help on this aspect. So I am very thankful to Dr. Maninder for choosing this subject and selecting real experts on this field. And I'm happy to see Dr. Narendra, Malhotra, Dr. Hemantha, Perera, Rubina, Hussain, all experts in this subject present today to give their expert comments. And then, of course, there are Professor Zinnat and Professor Arifa who will be giving lectures, and there will be a very interesting panel discussion. So I think this has been very well organized, and I'm sure this will be very useful for all the participants. Just before ending, I would like to remind you that we will have our main Congress in Pakistan. And I'm thankful to Professor Rubina, Hussain and Professor Batul for organizing this. So we will hear more details of this congress by them from them. So thank you very much, and I hand over back to the moderators to continue with this program. Thank you.
Thank you, Dr. Rohana, for those kind words. And you have been always so supportive that I am really privileged to have you as our president of the SAFOMS. And under your guidance, I think we have grown a lot because we are making lots of connection, and now the local menopause societies are coming forward and participating in the SAFOMS webinars. This webinar today has a talk by Professor Zinnat Nasreen on the whispers of the heart also, along with the sexuality issues, which is from the Dr. She has joined or not, Dr. Iftara? Okay, so this is our fourth webinar. First one we had done in 2020, and the 3 webinar series we have done on the menopause rating scale, hot flushes, mood and sleep disturbances, and sleep disorders. So we have covered them. Today we are covering 2 issues. One is the sexuality issues, and the second is whisper of the heart. And we'll be doing a panel later on. So we welcome all the chairpersons, esteemed chairpersons, who are the experts also, and very expert panels. And my special welcome to Dr. Saida Batul Mazhar also. We are having our SAFOMS, of course, annual conference in November in Pakistan. I'll be showing the flyer also later on. So Professor Rubina Hussain, welcome to you. She's so dear to us because she is the founder member of the SAFOMS, and she has been persistently with the SAFOMS, and she was the past president of the SAFOMS also, and president of the Pakistan Menopause Society. As I'm requested again and again that the CV should be 2 or 3 lines only. So please, all of you can read it. And then we have Dr. Hemantha Perera, who is the senior lecturer at the Perera Medical Faculty and consultant for 29 years at Matara, Ratnapura, and Perera and Silke. And then we have Professor Narendra Malhotra, who just does not need any introduction, because one who doesn't know Dr. Narendra Malhotra does not know anything about the gynecology. So he has been with all the institutions and managing director, Global Rainbow Healthcare. Welcome, Dr. Narendra Malhotra, and I am really honored to have you here. Our speaker will be introduced by Dr. Narendra Malhotra, Professor Zinnat Nasreen, whose topic is Whisper of the Heart now. So we can start with our...
It's my great pleasure to see that the first question has already come there. Do adults need sex education? So I don't know. So I think adults do need sex education, and everybody needs sex education at every stage of life. So there is something different which should keep the fire and the spark on. So yes, we after we hear what Zinnat has to say, we'll tell you what type of education do adults need. So thank you, Dr. Maninder, for inviting me here. I'll be off and on because there's another webinar and a physical meet also going on in Agra. So, but I'll be listening to you and I'll try to answer as many advice I can give. Thank you very much.
Thank you very much, Honorable Chairperson, Chief Guest, and all the dignitaries here with the convener. Salam alaikum and very good afternoon, evening, and greetings from Bangladesh. Well, my topic is the whisper of heart from the mature women. Well, I don't have any disclosure, and I'll talk a little bit about introduction, the risk epidemiology, pathogenesis, role of MHT, and prevention of cardiovascular disease. Women are the best unique creature in the nature. She is the blessings and gifts from Almighty. She gives birth of children, rears and looks after the whole family, and that is the whole nation. So she is the nucleus of family. So her heart matters, her health matters. But unfortunately, 2/3 of the death of these women is because of heart disease. Therefore, we need to listen the whisper of her heart and protect her heart to be diseased so that she might get a healthy life with full of quality and joy. Well, we know that menopause and beyond, there are a lot of climactic symptoms appears, like hot flushes, night sweats, musculoskeletal pain, genitourinary syndrome of menopause, but those are not a killer disease. On the other hand, heart disease is a disaster for women in her menopause and beyond. The chronic heart cardiovascular or coronary heart disease increase with aging in both men and women, but the menopause has an additional effect on women. And if you look at the epidemiology, the evidence suggests that menopause increases 2.6-fold more cardiovascular disease, and especially the early menopause and POI are associated with additional 1.5 to 2-fold increase in cardiovascular disease. Chow et al. Showed a beautiful study he has done that 48% higher risk of ischemic heart disease in POI, that is estrogen deficiency or POI, is independent risk factors for cardiovascular disease. But what about the mature women? Menopause and beyond, I think this is the starting of a new era. And all women, we need to screen, diagnose, and intervene CVD as earliest. Estrogen, you all know, it is a cardioprotective, but soon after menopause, estrogen production ceases. So the protective behavior on her heart is withdrawn, and she becomes very much vulnerable to heart disease, unlike in her youth. So if you go for the pathology, pathophysiology, estrogen has a very good effect on the vessels and the heart. How? It is a positive effect on the endothelial function, a vascular tone, cardiac function. It keeps all the blood vessels flexible and dilated and decrease the peripheral heart resistance. Therefore, the dilated heart is the happy heart. Most importantly, estrogen reduces the tumor necrosis alpha and increases the prostacyclin 2, which reduces the oxidative stress and platelet activation. Therefore, it also increases the production of apolipoprotein A and decrease the hepatic lipase activity, thereby facilitated to increase the high-density lipoprotein and also clearance of the postprandial chylomicron. Therefore, the low plasma estrogen, elevated LH, FH, have significant effect on plasma lipid metabolism that ultimately causes the risk of coronary cardiovascular disease. Though the global issue is the cardiovascular disease, the rate of increase of cardiovascular disease in developing country is very alarming. It is almost double the comparison to developed countries. And it is wondering that after the menopause and that beyond, estrogen deficiency changes the body fat distribution from gynecoid to android pattern. And it reduces the glucose tolerance, endothelial dysfunction, increase the vascular inflammatory markers, which also the surrogate markers of the metabolic syndrome. Interestingly, women experiencing vasomotor symptoms have a significant higher blood pressure, higher cholesterol level, and higher BMI, which increase the cardiovascular disease than their counterparts. On top of that, if they have got the smoking, diabetes, raised blood pressure, and so on, that is the disaster. So how to get rid of that? Well, heart healthy lifestyle is the main target. You all know that we have to maintain the BMI, avoid and quit the smoking, avoid excessive alcohol consumption, maintain the healthy body weight, and regular exercise. And of course, the treatment of comorbidities is important. And women have to also explore that bring them pleasure and what make them happy. They need to actually refine themselves. Exercise, all we know that it is the bedrock of lifestyle modification. And at least they have to do 150 minutes exercise or walking during a week. And also they can increase to 300 minutes in a week. Actually, it depends upon how much exercise they will do according to their need, including the muscle strengthening exercise. Of course, walking, cycling, swimming, and dancing or yoga, all are the good exercise. Now, I'll talk about the menopause hormone therapy. The landscape of menopause hormone therapy is changing time to time. So the healthcare providers and women becomes confused whether they will take it or not, especially on the standpoint of cardiovascular disease or cardiovascular health. Well, Mortellon S has a huge systemic review of 951,000 women, and they found that metabolic syndrome is more in mature women, that is postmenopausal women, and that metabolic syndrome, if they have, is associated with a twofold increase in cardiovascular outcome and diseases and 1.5-fold increase in all causes mortality. So this is very important, and it has been shown that MHT, if started early, it slows the progression of atherosclerosis, prevent a new onset of diabetes, and thereby it decreases the risk of metabolic syndrome. The role of MHT has been reviewed by, we all know that back in 2002, the WHI, they published that MHT is associated with the high risk of stroke, cardiovascular disease, coronary heart disease. But that study was biased because they included mostly the elderly ladies who are already having diseases, and there is only one kind of hormone therapy, and particularly they use the estrogen along with the progesterone, androgenic progesterone. So that was a bias. Therefore, the whole study was being revisited, reanalyzed, and in 2013, the global consensus issued by almost all the menopause societies and with the Cochrane review stated that standard dose of estrogen alone may decrease coronary heart disease and all causes of mortality in women younger than 60 years of age and 10 years of menopause. So the benefit of actually MHT is it will depend on the timing hypothesis, the timing of initiation of the administration of MHT, the dose of the MHT, and the character of the MHT, which kind of estrogen and progesterone are being used, and also the duration. Estrogen is protective in younger women, I have already mentioned, but if it has been given in elderly women who are already having atheroma, it doesn't give any beneficial effect. And heart study, probably you might ask what happened to the heart study, why it has been stopped? Well, in the first year of the study period, there was a sudden increase of coronary heart disease, but that is also reanalyzed, and it has been seen after cumulative ages. The heart study also showed that yes, there's a decrease in coronary heart disease. Regarding the KIP study, yes, the estrogen replacement and atherosclerosis trial reported that MHT reduces the climactic symptoms of menopausal women, and it reduces the low-density lipoproteins, but it doesn't alter the carotid intima media thickness. On the other hand, the DOP study, that is Danish osteoporosis study, it is a 10 years of MHT trial of osteoporosis, reported that women taking MHT had a reduced risk of mortality, heart failure, myocardial infarction, without an increased risk of stroke, VT, and cancer. And that was a very powerful study. Also, the Finnish study had the same notion. The ELITE study, that is actually an early versus late interventional trial with the estradiol study, showed the progression of subclinical atherosclerosis is slower in early intervention group, but in the later intervention group, there's no risk of the cardiovascular disease, but there is no benefit. And WHI also, we have seen from their study that estrogen therapy use was associated with a significant reduction in the coronary arterial calcification. Of course, the dose I have already mentioned and the character of the MHT is important. That is, the transdermal estrogen and natural progesterone is the very, very heart-friendly regimen. We are very curious about the serum. Well, the SMART trials have gone a step further in evaluating effects of conjugated estrogen and bezodaxifene, that is the SMART on postmenopausal women. And at 12 months, they have found this combination was associated with significant improvements in total cholesterol, and also there's a decrease in low-density lipoprotein. So, but one thing is important, that women with known cardiovascular disease, if they're on combined MHT, particularly oral estrogen, they have higher risk of DVT. Well, probably I can convince you that MHT is beneficial on the standpoint of cardiovascular disease. But before starting MHT, this is very, very important to get the whole history, detailed physical examination. And if we feel that, yes, she is fit for that, then it is very imperative that both the patient and providers are aware of the appropriate indication of MHT for her case, individual risk, and especially from the cardiovascular standpoint. And all women with cardiovascular cases, they should be assessed for the risk of cardiovascular disease. And if high risk, no MHT. If a definite risk, we could be cautious. If low risk, we can provide the MHT. And this is the Sidhu Paravakan. They have said, they have seen and analyzes all this data, also the journal in metabolic. And they have said the bottom line is that at present, MHT is not for primary or secondary prevention of cardiovascular disease. But definitely, if women who are getting the MHT for other climactic symptoms, definitely they prevent the progression of the cardiovascular disease. Angela HEMS, very recently in 2021, they have mentioned, along with the American College of Cardiology, and the message is that NAM's position paper outlines an individual approach to cardiovascular risk assessment. Whenever we are prescribing the hormone replacement therapy, we have to have individual assess the women individually for whether she's having cardiovascular risk or not. And then we can recommend the low dose MHT for a short period of time for the management of severe menopause climactic symptoms. Well, if we hear the whisper of heart, we realize that it also focuses towards the mental happiness, not only physical symptoms, to improve the quality of life, which might prevent the premature death. Therefore, women should continue to take the vacation she loves. She should quit to be overburdened. She should quit burnout syndrome, and she should spend time with the near and dear persons to have a quality time. And she needs to go to the close to the nature, which freshens her heart and soul. And she should keep walking, moving as much as possible. So the self-care is that's very important for her, and she should get their annual checkup following the screening program that is recommended in her country. And current evidences suggest that consideration should be given for the use of MHT for climactic symptoms, which might prevent the prevention of future cardiovascular disease. So if I can make a gist, the important thing to listen our whisper of heart that our women have to heart healthy lifestyle. She has to adopt the heart healthy lifestyle. She needs to take her self-care. She should have a mental recreation, avoiding the sedentary habit. She stops the smoking. She should minimize her alcohol intake, regular health check with a tight control of her comorbidities, and of course, menopause hormone therapy if indicated. So I'd like to conclude saying that the whisper of heart needs to be louder, but to live while women are living with full of joy and laughter and forgiveness. Cardiovascular prevention need to be addressed at early age, not at the time of menopause. And it should be addressed by adopting the heart healthy lifestyle with optimum diet and exercise. MHT need to be individualized. Starting MHT early and window opportunity gives the maximum cardiovascular protection, and heart-friendly MHT, that is the transdermal estrogen with natural progesterone, should be the first choice of preference. And finally, we need more rigorous research to help us on better understanding of menopause and cardiovascular health. Thank you very much for the kind attention. Let us have a good heart to live long. Thank you very much.
Zinnat, that was a wonderful presentation. We'd like to have a few comments from our chairpersons, Dr. Hemantha and Dr. Rubina Hussain and Dr. Narendra Malhotra. I agree on 2 points. One is the atheroma. When it's there already, if we give menopause hormone therapy, it is very dangerous. And secondly, we don't have any research. Where is the whisper coming? We just don't have our own data, and South Asian countries should have their own data, because it's very simple to collect. What are the risk factors for us? We are not hearing that whisper, and we have seen so many colleagues landing into MI when they started the HRT, though within the window of opportunity, but maybe there were some risk factors which we missed in those cases. That's why I think research is needed. Comments from the chairpersons now?
What we need to understand is so many things in aging population, and especially menopause, because this is a turn which a woman undergoes, and we have to make these waves very, very smooth sailing for her. So the waves of menopause has to be sailed smoothly, because it's going to affect all the systems and cardiovascular health, because women heart attack increases after menopause. They're much protected much before that, more than men. And so that's very nicely brought up points by Dr. Zinnat, especially stressing upon the lifestyle and the nutrition, and of course the MRT to be started at the right time. So once again, congratulations for organizing this webinar and for bringing out issues of menopause in the understanding of the doctors. Thank you, Dr. Maninder.
Thank you. Dr. Rubina?
Thank you, Maninder. Congratulations to Rohana, the whole SAFOMS team, and we are so blessed to have Maninder with us, an active person, and she's doing so many webinars, and I am so proud of her. You go back to Congress, and every time I come here, I have to remember Behram, Uncle Saria also, because he was the initiator. And this was an excellent presentation. Well done, Maninder, for bringing us together and keeping us together. Right from WHI, you came to the more recent ones, because now in the recent media, there has been a lot of controversy again that there are problems with MHT. So I think you are right in the end that we need more and more research. And like Maninder said, more in our part of the world, because like in the Western population, whereas hot flashes is the leading perimenopausal symptoms, and in our part of the world, it's body aches. So we need more. And again, I congratulate Maninder, Rohana, and our entire team.
Thank you, Rubina. Dr. Hemantha?
I think we have covered a very good area, quite in depth also. Probably we have to look at what the new evidence which is coming up. And until the new evidence says something different, I think we have to stick to the guidelines which have been given by most of the national societies, and that have been amply demonstrated by the present results. So thank you very much for the excellent presenter. Thank you.
Thank you, chairpersons. And I take this opportunity to remind all of you that we are doing a research project of relationship of menopause to metabolic syndrome under the banner of South Asian Federation of Menopause Societies. And so far, because of some regional problems, the Sri Lanka and other countries have not been able to join. I request all of you to please start collecting your data, because from India, we have enough data now. And it's very disheartening to see that data, because lipid profile and waist circumference, they are increasing as soon as we are crossing our 40 years of age. So please collect that data. And thank you to all the chairpersons. Now we invite the second chairperson. Dr. Hemantha, you can invite, or Rubina, you can invite.
Professor Arifa Bari is the professor in the Department of Obs and Gynae at Foundation University School, FUSH and FOGSI Foundation. And she's a supervising examiner for the College of Physicians and Surgeons. So without wasting much time, I would like to request her to talk. She's a new member, so we should give her a very warm welcome. And she starts, I think. Let's not waste time and just start with the presentation.
Yeah, welcome, Professor Arifa. Please share your presentation.
Okay. Thank you so much, ma'am, for inviting me. Thank you so much, ma'am, for inviting me. And I owe this, and I dedicate this presentation to my worthy supervisor and Professor Sayyida Batul Mazhar, who encouraged me to present in this August forum. And I have no experience in this topic before, because this is my first encounter, and I just went through this topic recently, because we are just doing general gynae practice, and we are not very much into this rare topic, which is which I found interesting. So I will discuss mainly the different problems associated with sexual dysfunction in the midlife and related to menopause. Sexuality is an important component of a woman's life. However, multiple genetic, biological, emotional, hormonal, and social factors may influence the female sexual functions. And as the maternal age is, as the women age is increasing, life expectancy is increasing. So many of the women are living in their 1/3 of their life in midlife and in the postmenopausal age group. And both the increasing age and natural menopause have a significant negative impact on sexuality, especially libido, arousal, orgasm, desire, and sexual activity. But the problem is that very small percentage of midlife women report their sexual problems in a medical setting as opposed to the men, with the result that the adequate treatment is rarely sought. So these barriers are also because of the inadequacy and faults on the part of the healthcare providers because of the scarcity of specific knowledge and time. So what we consider normal? The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality. And it is not merely the absence of disease, dysfunction, or infirmity. And the normal sexual response usually has 4 phases: desire, arousal, orgasm, and resolution. And here the 4 phases are present both in men and women, although the timing usually is different. For example, it is unlikely that both the partners will reach the orgasm at the same time. And the first phase, that is basically the desire, in which the arousal or excitement are basically overlapping, followed by plateau, orgasm, and then resolution. So basically, sexual desire is the first step or the first stage of a female sexual cycle response, and it is the interest in the sex and in being sexual. It has 3 interrelated components, which is the drive, which is a biological component, the beliefs, values, expectations about the sexuality, motivation, and the social factors like cultures and upbringing, and all those things are the related factors which affect the drive of the or desire in the sexual activity. The next is the arousal, and it involves the physical signs of sexual readiness. And although sexual desire often triggers arousal for many women, particularly after menopause, sex drive may no longer be the first phase of sexual response. Instead, desire will follow arousal. So they are just first steps, but they can interchange depending upon the patient's condition and scenario. So the different sexual problems that can arise, female sexual disorders in the midlife, are associated with reduced desire, or they decreased desire, ending up into a syndrome called hypoactive sexual desire disorder. There can be decreased arousal, there can be a decreased response and pleasure, and in the form of a pain like dyspareunia. And there are many types of risk factors which are associated, and they affect all the phases of this sexual cycle response. I'll just give the brief details. What is hypoactive sexual desire disorder? For many women in life, the gradual decline in sexual desire does not have an impact, and they does not affect the quality of their life. But for others, this diminished desire may be very distressing, leading to a hypoactive sexual desire disorder. And for this, it is mandatory that to evaluate the presence of sexually related distress in order to diagnose hypoactive sexual desire disorder. And as you can see that 70% of the women may feel that they have low desire, but actual hypoactive sexual desire disorder is present only in 30% of the patients. And the additional factors that can aggravate or that can affect the syndrome, disorder in the midlife woman is basically vaginal dryness, pain during sexual intercourse, moderate to severe depressive symptoms, and use of psychotropic medications, which are these conditions are usually present when the women are approaching menopause. So there are various causes of sexual problems at midlife. These can be hormonal changes due to normal aging process and menopause, genitourinary symptoms of the menopause, GSM. They can be vasomotor symptoms of the menopause, depression and mood swings and anxiety, which can be related to the menopause, or it can be a personality disorder already affecting the women. There are many women who are suffering from different medical problems and they are taking medications in the midlife. They have also effect on the sexual problems in the midlife and sexual health and sexual activity of the women. Similarly, stress of different various social and family stresses, fatigue at this age, and relationship issues, very important, can affect the sexual activity and sexual life of a woman in the midlife. Menopause and sexual dysfunction is very much related, and the sexual functions worsens with advancing menopause status independently of the age. And the common problems seen are low sexual desire, poor lubrication, and dyspareunia. And what factors at the time of menopause affect and cause these sexual problems are basically hormonal changes. And previously, the low estrogen associated with the menopause was considered as the main reason for different sexual disorders. And estrogen affects at all stages of sexual cycle response, right from the neuronal system, brain system, and acting through the neurotransmitters and causing at the periphery by causing causing these genitourinary symptoms of the lower genital tract. But recently, it has been seen that the low testosterone in the aging women as well as associated menopause can lead to a sexual dysfunction. And the commonest dysfunction, which I have already discussed, is hypoactive sexual desire disorder, which is very much associated with low testosterone level. In menopause, the ovarian production declines, and in aging process, the adrenals also affected, and the testosterone production from the adrenal also declines. And that is why the low testosterone production is more commonly seen in those women who undergo surgical menopause, because after removal of the ovaries, there is a sudden drop in the low testosterone level, and it is more common associated with hypoactive sexual desire disorder. The next changes associated with the menopause is the basically genitourinary symptoms of the menopause. Previously, there were many names given to it, like vaginal atrophic vaginitis or dry vagina or vaginal thinning, but collectively now it is called genitourinary symptoms of menopause because it affects the genital as well as the urinary tract. And about 50% of the middle-aged women are affected by GSM, and it is basically caused by the low estrogen levels at the menopause. The other factors that can aggravate GSM include smoking, alcohol, decreased sexual frequency and activity, lack of vaginal birth, cancer treatments, and pelvic irradiation. And it affects the vagina, and the patient's complaint is basically reduced lubrication, dyspareunia, and postcoital bleeding at the time of sexual activity. So these are the lower urinary tract symptoms associated with GSM: stress incontinence, mixed incontinence, recurrent lower urinary tract infections, and overactive bladder. And similarly, the vaginal atrophy causes dryness and soreness and painful sex. And there is reduced blood flow leading to reduced arousal and reduced and painful sexual activity. Similarly, the vasomotor symptoms of menopause, they do not directly affect the sexual activity, but they can indirectly affect the quality of life, leading to the problems in sexual, like causing sleep disturbances, excessive sweating, lack of energy, and general negative impact on quality of life. Overall, have a bad effect on the sexual behavior and sexual activity of the life of in the life of menopausal women. Similarly, the psychological symptoms, depression, anxiety, all these can contribute to the sexual dysfunction in the females. And their relationship is very much complex. Depression can both be a cause or can be a result of sexual problem, because if it is a cause, then it can result into distress, and it can lead to a distress syndrome, like I have already discussed. Similarly, the changes which are taking place in an aging woman may be associated with the menopause, and also due to the aging, there is weakness of the pelvic floor muscles. They can lead to different problems in the genital tract. There can be weakness of the ligaments and muscles, and there can be anterior vaginal wall prolapse, and these prolapse cases, or even there can be a posterior vaginal prolapse or uterine prolapse. These all affect the sexual activity and sexual behavior of the women in the midlife. The other illnesses, medications, chronic illnesses can affect the, at this age, many women are suffering from different chronic illnesses, and these also affect the quality of life and sexual life, especially in these middle-aged women. The most common ones among women at midlife and beyond are diabetes, heart disease, high blood pressure, cancer, arthritis, and chronic back pain. And as the diabetes is very common, and in diabetes, there is decreased sensation leading to decreased arousal, and also the blood flow is reduced in the vagina because of the dryness, and because of the reduced blood flow, there is lubrication and arousal problems. And heart disease again affects the blood flow and leads to lubrication and arousal problems. So what is the basic concern? Why we are basically concerned? The problem is that many people feel embarrassed to talk to their partners, friends, and even healthcare professionals about the sexual disorders or sexual problems they are suffering. And only a quarter of affected women seek treatment. And the problem is that many of the healthcare professionals are not trained enough to treat and manage these problems, because in general gynecology, this is not a very much addressed problem in the healthcare professionals. So there are different management options available for menopause related and also other causes leading to sexual dysfunction in the midlife. And these include education of the women regarding the risk factors, and then general advice about the weight loss, exercise, and healthy living. There may be sex therapy and counseling, and the symptoms of menopause can be treated with the hormone therapy. The psychological symptoms and hypoactive sexual desire disorder can be treated with psychotherapy or with the help of antidepressants, sexual devices, and laser treatment. These are the management options available which can be offered to the women suffering from various sexual dysfunctions. The hormone therapy can be in the form of HRT, estrogen alone, or in combination. It can be in the form of local estrogen therapy, or it can be in the form of SERMs or tissue selective estrogen complexes, or it can be in the form of androgens. So local estrogens helps in improvement of vulvovaginal dryness and the soreness, burning, irritation, itching, and are likely to respond to local estrogen therapy, which can also help greatly with discomfort and pain during the sex. And it can be delivered in the form of tablets, creams, or in the form of different regimes. And local estrogen therapy is basically given on those patients who are suffering from GSM and in which we want to avoid the systemic effects of HRT. And HRT basically improves the vasomotor symptoms, and that also improves the sexual disorders in the women if they are affected by severe vasomotor symptoms. But local therapy helps in local control of the local symptoms. And similarly, the SERMs, which are selective estrogen receptor modulators, Osmifene is a selective estrogen receptor modulator. It is taken orally in a dose of 60 milligrams once daily, and it can be used in women with history of breast and endometrial cancer who have completed their treatment. And hot flushes is usually the side effect of this drug. They are delivered vaginally in the form of pessary, or they are converted into vaginal mucosa to both estrogen and testosterone, and 95% of the active hormone made in the vaginal mucosa are inactivated at the site of synthesis, and this leads to the increase in the hormone levels in the bloodstream and estrogen improvement in mucosal thickness. Androgen improvement to connective tissue and stimulation of the muscle layer below. So these are the effects of SERMs which we use locally for the management of local symptoms. There are various non-hormonal treatments available, like central nervous system agents for hypoactive sexual desire disorders in the form of antidepressants, or there can be vaginal moisturizers and lubricants where we cannot give even local hormonal treatment in the form of testosterone, or in the form of estrogen therapy. We can use vaginal moisturizers and lubricants to avoid the symptoms of GSM. And the upcoming are the laser therapies. The new addition to these managements is the laser therapy. And this vaginal laser therapy is the recent development. It is an alternative to existing treatment choices, and it stimulates collagen producing fibroblasts associated with urogenital tissue structuring, increased vaginal lubrication, and acidity. And various types of laser treatments are available. So in summary, sexual disorder in women is common, and it is caused by various risk factors that go beyond estrogen deficiency. And basically, it is underdiagnosed and undertreated. And there are a number of effective treatments that can be given to treat the symptoms easily and effectively. And sexual dysfunction can be an embarrassing condition, but it needs to be addressed, and education of both the healthcare and professionals and the patients is very crucial. Thank you so much for patient listening.
Thank you, Dr. Arifa Bari. Congratulations and welcome to the fold of menopause. When I started these webinar series, my purpose was to involve more and more of younger generation into the menopausal medicine. That is the only way we can grow. That's why I made it a point that the speakers will be young residents or young professors in the field who will be introduced sort of into the menopausal medicine so that they can have an active interest. So you have given a wonderful presentation. I'll request the chairpersons to please give their comments. And you have covered everything, but let's see what our experts will be doing, because then we have a panel where our experts will discuss threadbare these situations and problems. Yeah, Dr. Rubina, please unmute yourself. Dr. Rubina, unmute. And thank you, Dr. Saida Batul, for giving us a very, I think, diamond for the Menopause Society, another upcoming person. And I think involve her in that research of relationship of menopause to metabolic syndrome. Give her, she'll collect the data.
Can I come in, Maninder?
Yes, Hemantha, please.
Yeah, that was a very comprehensive presentation. I was just wondering whether the SAFOMS should pay more attention to the sexual issues, particularly of women in our region, because there are most of the evidence which we are discussing and the presentations are based on Western information. But we very well know that there are a lot of cultural issues, economic issues, which are particularly affecting our type of setup. And that can have a bearing on the sexual relationships. So maybe like the research which you have taken up already on other things like cardiovascular system and all that, this may be pertinent to have our own research data on sexual dysfunctions. Thank you.
Thank you, Dr. Hemantha. That is the purpose of this webinar series on the menopausal symptoms, so that we involve more people and they get the more ideas and the more research is done. Because I think South Asian countries have to prove themselves that yes, we can collect our own data and our own research. Thank you. Dr. Rubina.
Thank you very much. First, congratulations to Batul, who pushed her trainee, who has now become a consultant, to do this, because this is the purpose, like you said, of SAFOMS, to bring in young blood. Just one little correction. She used the word HRT instead of MHT, which is the new term used. So we should use the word MHT, but very well done. This is a very unspoken taboo. People have 3 children and they've never had orgasm or whatever. So we see this a lot, because especially in our part of the world, women do not talk about it openly, and this needs to be addressed. The problems need to be addressed, and very well done. I think a very good effort, and let's carry on with the program.
Yeah, Dr. Narendra Malhotra, because his is the favorite topic.
Narendra is doing 3 things at one time, multitasking.
Yeah. Anyway, I think he has left for the time being. So we will be, I think, start with our panel discussion on sexuality issues now. Deepika, can you please share the CV slides, and can you please show us the previous webinar flyers if you have with you?
Ma'am, after this, can I show you?
Okay, then after this we'll be doing. So we have a very luminary of the panelists from each country of SAFOMS. We have from Pakistan 2, we have from Bangladesh 2, then we have from India 2, and we have Sri Lanka 1 and Nepal 1. So I welcome Dr. Professor Sleha Begum Chaudhary, who is the former chairperson at Professor Department of Obstetrics and Gynecology in the Bangladesh. So welcome to this panel, Professor Sleha. Then please to the last, you have just skipped. Yes, next one. We welcome our very worthy and senior Professor Brigadier General Suraya Rahman, who is there despite being the fact that she was not well, and still she has joined, and I'm really thankful to her. And she was the ex-head of the Department of Obstetrics Gynae with the Ministry of Defense of Bangladesh, and she is at present the Vice President of SAFOMS. Welcome to Brigadier General Suraya Rahman. Next panelist. Professor Shaheen Zafar, who is the co-chair of the Kuhi Goth Hospital Obstetric Gynae Department and medical director of the Sindh Institute of Reproductive Medicine, IVF specialist and consultant, Atia General Hospital. She's from Pakistan. Welcome, Professor Shaheen Zafar. Then Dr. Rohana Gul, she's also from Pakistan, and she's the clinical sexologist and fertility specialist. So welcome, Dr. Rohana Gul. And now it's my great honor to welcome my very senior Harshapatu Atapatu from Sri Lanka, who is going to be the next president of the Sri Lankan Menopause Society, and is the consultant obstetrician and gynecologist, Disoesa Hospital for Women, Colombo. Next. And then we have from India, Dr. K.S. Jayarani Kamraj, who is a senior consultant, reproductive medicine, infertility and sexual medicine, and director, Akash Fertility Center and Hospital, Chennai. And she's president of the OBGYN and treasurer of the Tapisar, Tamil Nadu Association. Welcome Dr. Jayarani to this, because she is standing for the chairperson of the Sexuality Committee of FOGSI, and we wish her best. Then welcome Dr. Professor Ambuja Choranu, president of the, just past president of the Indian Menopause Society, and she is the research committee chairperson of the SAFOMS, and retired professor and HOD of Institute of Obstetrics and Gynae, Osmania Medical College.
Okay,
welcome.
Thank you.
Yeah, welcome to Aranur. And then we have Dr. Saroj Prasad Oza from Nepal, who is the professor and head department since 2015 in the psychiatry, Tribhuvan University Teaching Hospital, Kathmandu, Nepal, and past academic assistant dean of Institute of Medicine, Tribhuvan University. Welcome, Dr. Saroj Prasad Oza. So this completes our panelists. All the panelists to this panel of heart and sexuality in menopause. And we have already introduced our panelists, Brigadier Suraya Rahman from Bangladesh, Professor Dr. Rohana Gul from Pakistan, Professor Shaheen Zafar, Pakistan, Dr. Harsha Atapatu from Sri Lanka, Jayarani Kamraj from India, Choranur Ambuja from India, Professor Saroj Prasad from Nepal, and Dr. Saleha Begum Chaudhary from Bangladesh. I think she was introduced or not? Anyway.
Yeah, she was introduced.
Yes, okay. So healthy and satisfying sex life is an important component of overall well-being for many middle life women, and multiple studies have shown positive association between sexual function and health-related issues of life. We are living in an aging world, so why the issue? Midlife women are increasing in number, and then the years they have to spend in menopause. So sexual well-being is a very important quality of life issue. So this may seem unattainable for many women because this is dependent upon psychosocial circumstances as though biological changes at menopause may be associated with significant personal and relationship distress. And studies across a number of countries have shown that women place high value on sexual intimacy in their relationship. So this topic is of utmost importance. But I know this has been very rarely discussed issue, even with the patients and even in our scientific sessions also. So perhaps it will be very tough to talk about these things. Screening for female sexual concerns is often shortchanged during the clinical encounter because we as healthcare providers are not completely informed about it. Then they believe that such menopausal changes are normal and inevitable part of aging, and there are time constraints on the part of healthcare providers. So importance in relation to partner sexual dysfunction is also coming up because of the available of drugs like sildenafil. The men have longer life expectancy and sexual health also. So women also have to compare with the sexual health of the men. So sexuality is an important component in the lives of women now. And sexuality issues are not discussed. So women want us to come forward and discuss them. We get an opportunity. We should be discussing that, and we should be initiating the dialogue with the women on this topic. Then only will be aged. So what we are going to discuss in this webinar is to define sexual function and dysfunction, to present theoretical models of female sexual response, to examine longitudinal studies of how sexual function changes during midlife, and review treatment options and some discussions on menopause and heart and role of MHT. So women are distressed. They are distressed. Oh, I don't have the desire. Yes, he's not happy and maybe he will leave me. So we have to look into these issues of there. So I start with Brigadier Dr. Suraya Rahman from Bangladesh. What is the prevalence of hyperactive sexual desire disorders? Because first thing which we have to know whether this is important to discuss or not. To you, Professor Suraya Rahman.
Thank you, Dr. Maninder, and good evening, everyone. Special thanks to Dr. Maninder Ahuja for arranging such beautiful sets of seminar and giving me this opportunity of being the opening batsman as the panelist, as I already told that I was not keeping well for the last few days, just completed a course of broad spectrum antibiotics. But I really wanted to attend this webinar to get my little knowledge on this very interesting topic of sexuality at midlife, to enrich from your knowledgeable discussion. Because till the other day in this part of the world, as Professor Rubina Hussain said, she mentioned, it was a taboo. The sexuality discussion, we never had, especially myself, I hardly had any patient coming to me for such advices or such problems. So this is a topic I would like to attend and enrich my little knowledge. So with these few words, I would like to attempt to answer your question on the prevalence of hypoactive sexual desire disorder, a very difficult long name, with a little word of introduction, which should make my explanation on prevalence easier. So behind any discussion of sexual problems lies an incredibly loaded question. What exactly is abnormal or normal, healthy sexual response and function? I remember Professor Arifa Bari, she mentioned about the WHO definition, sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality, not merely the absence of disease, dysfunction, or infirmity. However, normal sexual response and function is about as individualistic as anything can be. Each person has own standard of sexual satisfaction basing on individual culture, background, personal experiences, and biological makeup. And this is more strongly so among the women. This is my theoretical knowledge, of course. So I would like to say that the prevalence of your question was prevalence of HSDD, which is hypoactive sexual desire disorder. The prevalence of HSDD is difficult to determine and has varied among different studies. This is because disparate estimates of prevalence may reflect differences in the age of the study group, different criteria for diagnosis, and study inclusion. A PRESIDE study reported prevalence of sexual distress symptoms, including hypoactive disorder, which was the most commonly reported. It peaked in the middle-aged women. 18 to 44 years, it was mentioned as reported as 8.9%. Between the age of 45 to 64, 12.3%, and 7.4% of women over the age of 65 had low desire and less distress. So it's interesting to know that as age advances, problems increase, but distress is also decreased. Studies indicate that female sexual dysfunction is a real burden for many women, and approximately 1 in 10 may receive a diagnosis of hyposexual disorder, disease, or distress. And I think the speaker also mentioned about the incidence. Incidence is more in surgically induced menopausal women, 26 versus 14% compared to gonadally intact women between the age of 20 to 49 years of age. These data suggest that women with surgical menopause should be routinely assessed for signs of sexual dysfunction, and if necessary, androgen therapy may be considered for them. I think this is enough to add to the question of prevalence. Dr. Maninder?
Dr. Suraya, you have really given a wonderful answer that you have suggested that it's not only hyperactive sexual desire disorder, HSDD, they encompass the complete physical, mental, and the psychosexual part of the women's life. So very important part of the quality of life issues. So now the second question is 46 years. Oh, no, I can't see. Yes, this is for Professor Dr. Choranu Rambuja. A 46-year lady comes to your OPD and she with amenorrhea of 1 year and she is complaining of hot flashes. But when subjectively inquired, because otherwise they never mention it, she mentioned that yes, she has loss of sexual desire in sex life. But does menopause really cause it, the sexual dysfunction, and how menopause causes the sexual dysfunction? Professor Dr. Choranu Rambuja.
Good evening, everybody. And at the outset, Maninder, congratulations to you for selecting such a wonderful topics for the seminar and making the SAFOMS live always. Everybody, you are stimulating with your letters and everybody is very active in doing. And previously it was not there. And second, the second thing is, yeah, hello.
Yes, you can continue, Choranu. She is talking. Dr. Zinnat, please mute yourself.
And second thing I'll tell you, and thank you for making me a part of this webinar. Regarding your question, a 46 years lady complains of sex problems, not able to eat. Two things are very important. This is a menopausal transition phase where the estrogens are fluctuating. Because of that, she's having hot flushes, irritability, and this again is one of the reasons. And estrogen is not completely deficient. It is the stages that is going on and off. Second thing, the vagina and genitourinary system has got the receptors of the estrogens, alpha and beta receptors are present in in vagina and all the genitourinary symptoms. But these receptors are more present in the vagina and the fornix than in the vulva and labia majora and minora. These two things are supplied by the androgen receptors. That is why superficial dyspareunia is more common in these people, even though we use the estrogen creams or any of the estrogen preparations. And deep dyspareunia will not be there. As my previous speaker said, the androgen preparations may help, or androgen creams may help for such people to have the thing. Many of the people, they complain. They have very bad superficial dyspareunia, and as they progress in sex, they are happy for that one. Maybe this is the reason why they are having. And menopause, dysbiosis is another reason for this. And normally, which are present the lactobacilli, is because of the dysformation of the epithelial cells. The epithelial cells will grow because of the estrogens and stratified squamous epithelium when it is present. It produces the glycogen, and the glycogen that is present, that is the diet for the organisms that are present. When this is not there, and all the pathogenic organisms will take there and produces the dry vagina and inflammation, which are again the reasons for the sexual dysfunction. And pelvic organ prolapse, sometimes it happens in the patients. Nowadays, we don't see many of the things, but because the rate of vaginal deliveries itself has come down, that is one of the things. It was there previously. Now I don't think that is present. But one thing I can tell you, for the patient which you have presented, many a times a repeat sexual act stimulates the vagina and vascularization, and this problem will come down usually. Do you expect anything more?
No, Dr. Ahuja, I think we'll discuss GCM later on in details. So now you have highlighted that there can be other associated problems with the menopause, along with the low estrogens and low testosterone.
Androgens.
Yeah, androgens. So that low androgens are also causing these disorders. And especially one point which you have mentioned is worth thinking, that the androgen receptors are present on the vulva and the deep vagina are present, the estrogen receptors. That is why when we are giving the creams also, they are not being effective. So these cases where they are not being effective, I think we can give the androgens, and we discuss that later on, the role of androgens here. Now the next question is for Professor Shaheen Zafar. What is sex response cycle? The first part is this: what is sex response cycle, and what are other models of sex response?
Thank you very much for making me part of this wonderful webinar, especially Maninder for you. Your thanks. This sexual response cycle has been discussed by Dr. Arifa Bari already, so I will be short on this. The sexual response cycle has 4 phases actually. The first phase is desire, where the person desires sexual activity and may have fantasies. Women have more fantasies than men. So this is also called as a libido. Second phase is excitement or arousal, in which individual experiences a feeling of pleasure and physiological changes in the body. And it is where we also get sometimes sexual arousal disorders. The third phase would be orgasm, which is also called as a climax. And this is a peak of sexual excitement, both for male and female experiences, a release of sexual tension with rhythmic contractions of muscles and reproductive organs. I will discuss that in a bit more detail. The fourth phase is a resolution, where it's a general relaxation and a sense of well-being and euphoria. And sexual pain disorder or any type of sexual dysfunction can occur at any stage of these sexual phases. So the first phase was the desire, which is libido. During this phase, the muscle tension increases, the whole body tightens, heart rate, respiratory rate increases, and then the flushing of the skin, face, and whole body starts, and blood flow especially increases to genitalia, causing swelling of labia majora and also erection of nipple. Second phase is excitement arousal, in which breathing and blood pressure and heart rate is still increasing, and there is swelling of clitorius and engorgement of clitorius and labia, and the size of labia increases. It swells up, and actually vagina opens up. And at this stage, a lot of blood supply comes towards vagina, and vagina causes secretion that is transudate. It seeps through vaginal wall. There are no glands in vagina, but the fluid seeps through vaginal wall, and a lot of secretion is experienced by a woman. And that's where she gets a lot of discharge. And since this it causes lubrication on this. So after that, we get this, the woman gets this orgasm. Orgasm is basically involuntary muscle contractions with rhythmic contraction, which is all the muscles around vaginal barrel contract and relax, and usually it is 8 to 10 contractions for orgasm, and it hardly lasts less than a minute. Repeated contractions. And at this stage, heart rate, blood pressure, and breathing again higher up. And this rhythmic contraction also is seen in uterine muscles. And sex flushing is all over body. And then the last phase is resolution, when and she may get multiple orgasm. In case of men, they get once only orgasm, and they have to have a refractory period, but in resolution period. But in women, she doesn't get a resolution period. She doesn't need resolution period. She gets multiple organism, so there's no refractory period, and she can even have resolution without orgasm. It's not every woman feels orgasm. There are many women who never experience orgasm. But this phase has a sense of well-being and euphoria. And this average sexual response time is around 11 to 15 minutes. Now, these phases have been described by Master and Jones in 1960s. Then in 1970s, well, this is sexual dysfunction. This has been just described by my previous panelists, so I think we can omit this. And we could go to this thing, that in this is the hypoactive sexual disorder. We have done this. Yes, I'll stay here, please. So Master and Jones have described this cycle, these phases in 1960s. And then Kaplan modified it in 1970s. And then she says, and she very rightly says, that woman doesn't have to go through all these phases. She may not have desire at all. The sexual activity on female part never start, not never, most of the time never starts with desire. Her desire doesn't matter for starting of sexual activity. But after stimulation or maybe a bit of arousal, and after arousal, she starts her desire, and that desire becomes more, and the activity starts. So, and then there was another model, which was a Bonson model. That is described by it's a sexual cycle. It's not like 1 phase, 2 phase, 3 phase, 4 phase. It's like a cycle. It runs through the cycle, and there could be spontaneous sexual desire. There could be stimulated sexual desire. There could be biological, psychological, any type of stimulus, any type of triggering effect can start at any stage, any phase. It doesn't have to be first phase, second phase, third phase. It is a cyclical activity, especially in women sexual cycle. Men could be different. So that would, and that would affect, that would be affected by physical, emotional triggers and stimulus. And at the end, she will experience physical and emotional satisfaction, and with this emotional intimacy, and she will become receptive sometime only when a male partner causes some stimulus. So I think I will stop here. If there's any question, I would like to answer that. Thank you very much.
Yeah, Professor Shaheen Zafar, I think you have highlighted very important points, that the desire does not has to come from the woman itself. She can be stimulated by the partner's desire, or if she has liking for somebody, even thinking about that person is going to give her that desire, not person have. And all these things are combined together, because when we have to go into disorders of the sexual function, then these things become very important, whether she has the desire or she gets stimulated by the, at least by the partner's initiative also, or she does not. One thing which I was thinking was that the lubrication comes only when the arousal is there. And secondly, when the rhythmic contractions of the vagina are occurring. So can POP flaps can cause the interfere with these women's rhythmic contraction or orgasm, and these women can have the sex just later on without orgasm. So are these the women who won't have the orgasm? Can anybody contribute into this?
You are saying that prolapse
perhaps does not let them have the contractions which they should be having.
Yeah, I would think so. I would think so that if somebody has a cystocele, rectocele, significant vaginal prolapse, so that they might not be experiencing orgasm, or maybe very little of orgasm. But it's a well-known fact that all women don't get orgasm. And
So
some
that
women
is
never
very
experience
important.
orgasm.
Yeah, when the patients come to us, we have to examine them thoroughly. Not just the history taking, yes, you are not having the desire, but why they are not having the desire or why they are not having the orgasm is very, very important. So this sex response cycles are very important, because initially they thought the desire was not important. They started with the excitement and arousal itself, but later on they realized that the desire was important. Now, one important thing, can any one of you tell how many calories are used during one sexual intercourse? Because sometimes when we started discussions on these things, so we used to talk whether we can use some calories also. So in this sexual,
250 to 300 calories.
Yeah, Rani, I thought they were just 80 calories.
200 to 250 calories in a sexual act.
So
that is a
when we
very
want
good
to
exercise, they
lose
say.
weight,
Yeah.
So it helps us keeping in healthy in that way also.
Yes, yes.
So the only thing is, in heart cases, perhaps the strong increase in heartbeat and everything pulse, they may not be healthy for them. So anyway, we'll be coming to those discussions later on again. And next question is, according to this, that is the manual of the mental disorders, on by for Dr. Professor Rose Prasad, how female sexual dysfunction is categorized in this manual.
First of all, thank you very much. Good evening and namaskar from Kathmandu. Thank you, Dr. Maninder, for giving me this opportunity. And Dr. Professor Chandra Srivastav, she is from Nepal, Menopause Society Nepal President. And the questions, as a psychiatrist, this is my first time I'm talking sexual dysfunctions in women. And as a psychiatrist also, in my 20 years experience, I don't have much, I couldn't face much problems regarding the sexual dysfunctions. But we generally, as a psychiatrist, there might be some comorbid other diagnoses, anxiety disorder, depressions. So probably we are dealing with under comorbid other diagnoses. And when we see this classification in psychiatry as a sexual dysfunctions, there are two well-known classification systems. One is DSM-5, which is American Psychiatric Associations, and another is ICD-10, which is World Health Organizations in 2019. And all the psychiatric disorders, they are categorized based on the description of the symptoms. So also here also in sexual dysfunction also, the symptoms, there are different types of disorder which we will discuss, classified in the DSM-5. And accordingly, we discussed, before that, we have already discussed about the sexual dysfunction you means. Actually, it's inability to respond to sexual stimulations or experience of pain during the sexual act, or it is inability to participate in sexual relationships, and a lack of sexual interest and willingness to be asexual. So these are some of the sexual dysfunctions definition we already discussed. So I don't want to take much time about the definition. Maybe the next slides I would like to say there are different sexual dysfunction mentioned in DSM-5. The diagnostic and statistical manual of mental disorder 5th edition shows there are 4 disorders. There are 4 disorders mentioned in the DSM-5. So as a psychiatrist, if we see the sexual dysfunction, especially in women's, there are also sexual dysfunction in the male also. So one is the female sexual interest or arousal disorder, which we have already discussed. The next is the female sexual orgasmic disorder. The another things which we have already discussed. The third one is genitopelvic pain or penetration disorder. And under this, you can see dyspareunia and vaginismus. And the fourth one is there are different psychoactive substances or medications or general medical conditions which can induce the sexual dysfunctions. So these 4 are generally categorized in DSM-5. And as a psychiatrist also, we make the diagnosis based on the various symptoms which are present, persistently presents, and at least for 6 months, if some of these symptoms, the hardcore symptoms presents at least 6 months, we can make the diagnosis, and the symptoms cause the significant distress in an individual. As we discussed about the sex is a biological needs, and there must be some kind of significant distress, and the symptoms is not explained by other mental disorder. There are some other mental disorder like anxiety disorder or the depressions where we can find also the sexual dysfunction symptoms, or it's should not be the consequence of relationship distress. Sometimes because of the significant stressor factors can cause also the sexual dysfunctions. And when you see the course and etiology of these sexual dysfunctions, it might be lifelong, it might be acquired, it might be situational, it might generalize. And when we talk the exact cause, it has got biological cause, psychological cause, physiological cause, and there are so many stressors, socio-cultural stressors, financial stressors, conflict. So based on this different psychopathology and the, can we see the management part? Yes. So based on this different 4 categories of psychosexual dysfunction, sexual dysfunction among midlife women, there are different varieties of treatment modules. And the most important modules, treatment modules might be psychoeducations, especially for the gynecologists, because the patients are not coming to us in psychiatry department because the problem is not the clear-cut psychosocial, psychological origin. So the important part is if we get the right information, if we get the support of women's having these sexual problems, probably if we give technical knowledge, the persons might be benefited. And maybe you can send to the psychiatrist or clinical psychologist for cognitive behavior therapy. This is another model. And the third model is dual sex therapy, or as already mentioned by the Master and Johnson techniques. This is another model where the behavioral therapists can treat the sexual dysfunctions. Another might be mindful meditations, group therapy, and that we can also mitigate the biological pharmacological risk factors. There might be many medicines, antipsychotics, antidepressant drugs, which can also cause, we can decrease that one. And especially sometimes, as we also biological, when we talk about the biological treatments, as a gynecologist, you must know the different types of hormonal therapies that can be helpful. So this is all from my side. So in conclusion, to me, from my side, that it is a complex issue, and it's a combination of the hormonal change, physiological, psychological, social, different aspects. So a holistic approach is needed to address all those factors. And actually, if we provide the appropriate informations, educations, and some therapeutic intervention, we can help midlife women's sexual well-being and enhance the quality of life. And thank you very much from my side. If any questions.
Thank you, Dr. Saroj Prasad. In your first sentence, you have highlighted our issues, that you have never treated the patients. So that is our problem. The patients are there, they are distressed, they need the treatment. That is why we need the update of the clinicians, especially the gynecologists, because they might be the first touch point in these sexual problems. They have to understand from the very beginning how they occur, what are the causes, and how we can manage them. So DSM-4, there were the female hypoactive sexual disorders and arousal disorders. They both were now merged into female sexual interest or arousal disorders. Orgasmic disorders are still there. Dyspareunia and vaginismus, they have been merged into the genitopelvic pain penetration disorders. And sexual aversion disorders are removed, and sexual dysfunction due to general medications are there, and medication-induced and general medical conditions are there. And then there can be not otherwise specified sexual dysfunction or unspecified sexual dysfunction disorders can be there. So now we come to the other very important issue to which we request Professor Rohana Gul to explain how to assess now these sexual interest and arousal disorders, and what are the validated questionnaires are there, how we as general practitioners are going to go into this, if there are any validated sexual disorders questionnaires are there, which we can keep on our desktop, and that can help us to diagnose these conditions. Dr. Rohana.
Thank you so much. This is Dr. Rohana Gul. First of all, I would really like to thank Dr. Rubina Sohail and Dr. Saida Batul as well for introducing me into this such an important webinar. And thank you so much for me to be on this boat. First of all, it's been 1.5 hours. Everybody is talking about these different types and different reasons why we are getting this hypersexuality in the middle age. We have 4 kinds of sexual dysfunction. So desire, arousal, orgasm, and pain, right? Very important is we have the questionnaire is SQoLF questionnaire, which is very specific and self-reporting instrument that focuses on the self-esteem, the emotional issue, and the relationship issues as well. It consists of 18 items, which is rated using 6-point scales. But again, as mentioned before by many doctors, I would highly recommend that all the questionnaires are from the West. We should have our own questionnaires according to our culture, according to our society, according to our religion. I can't just go and ask my patient in my clinic, hello, do you have sex with other person and do you enjoy it? I can't. That's my culture blockage over there, right? So let's say if a patient comes to me in my clinic with the desire issues, first of all, I need to stamp her with hypersexuality? I need to ask her that, do you enjoy watching something on TV? Do you enjoy or seeing naughty things on the TV? If she says yes, that means she's not hypersexual. That means she has a problem with her partner. She enjoys things around her, right? So this is very important. We can't just stamp every woman hypersexuality. Yes, they will say, I have no sexual intentions, but with why no hypersexual intentions? With her partner, with the specific partners. Obviously, you can't tell her to change your partner, but you need to tell her the different ways of having it then after the menopause. The arousal, you have to ask specific question that, do you get wet? That is very important. If not, in the mid-age, it is very common. Just use the lubricants. So assessing these 2 things are very important. Coming to the orgasm, does she know what is orgasm actually? I know the questionnaire would say, do you get orgasm? How would you get orgasm? How many times you get orgasm? But does she actually know what is orgasm? A lot of women come to your clinic and they would say, we have never had an orgasm in our life because they don't know what is orgasm. So that is also very important. And the pain. For pain, you have to ask whether the dyspareunia has been always there or no. We can't just say it's because of the menopause. Maybe it was always there. Keeping in mind when the woman ages, the man also ages. When the man ages, they have delayed ejaculation. So if the man has delayed ejaculations, keeping in mind, it becomes more like a painful sexual intercourse as well. Okay, so these things are very important that we should keeping in mind for all our questionnaires. Make your own questionnaires and publish them. It is very important, and it is, I think, the responsibility of this society as well, that we should make a questionnaire of our society, of our cultures, of our this Asia part, and we should publish it. There are a lot that you can find on the internet. The most important one, as I mentioned, is the sexual quality of life with the female index. They have 18. But in my clinic, I always ask about, do you have the desires? Do they have their own, at the same part, with the same partner, they have issues? Are they getting wet? They have communication issues. And obviously they have then the medical issues as well. In the same time, when in our society, the patient, the female partner, when they ages, there's a body shaming as well, right? Because we are not the same as we were in the teenage, in our 20s. So body shaming is also very important. So when a woman comes into your clinic with the menopausal, premenopausal sexual dysfunction, make sure you assess her. Why is that? So it can not be only because of the medical reasons. It can be because of different reasons as well that I explained it. And obviously all the sexual responses have already been explained. Nowadays, the best one that we use in our clinics and as a sexuologist is use Kaplan's model, because it shows the desire, the excitement, the orgasm, and all other with the resolution as well. But again, the woman is a very complex in nature. They can be of different, they cannot be desire, and they can jump into the arousals and the orgasm again. So I would end up here.
Thank you. Madam, you were given such a nice, wonderful description. And I'm so happy that our actually fundamental aim is being fulfilled. There's so much to discuss in sexuality. We will be late as our from our actually time which was being given to us. But the discussions are so interesting. I can't stop you people in between and tell you that please stop. Yes, you have said that we have to make our own questionnaires, and very important, we have to ask them, do you get wet? Because we cannot ask them in the other way, because they just don't know what the orgasm is. And you are right, many women, especially our rural areas, they never get the orgasm. They just are there for their men. So important that we have explained each and everything. I think we'll have to go quickly now because whole of the discussions are still there. So Brigadier Suraya Rahman of sexual arousal, desire disorders, they encompass some other factors also. What are those biopsychosocial factors which are involved beyond these desire disorders?
Thank you, Maninder. Before embarking on the question that you have projected to me, I would like to specifically thank Dr. Rohana Gul for wonderful, practical points that she has posed. A wonderful deliberation, I must say, and very, very nice suggestions for this part of the, world, specifically on such touchy, sensitive issues like sexual arousal, desire disorders, and such, topics. So coming back to your questions, I think everyone was talking in some or the other way on the biopsychosocial factors. But if you ask me, I would like to consider them, which is the factors that affect the arousal or desire problem. That was your question, isn't it? So I would like to consider them under the following headings to be more practical, like biomedical factors, which are altered hormone, neurotransmitters and their interactions, genetics, medical and psychiatric conditions, and beyond them, other factors are psychological factors. Dr. Ahuja was, elaborating on that. Situational stress conditions, boredom, self-consciousness about body image, Dr. Gul was saying, and distraction. Social and contextual factors like cultural norms, many speakers have mentioned, familial teachings and relationship consideration. These are very important, but I would like to say a few concluding words in this way, that the physical transformation the body undergoes with age have a major influence on sexuality. I believe that. Declining hormone levels, changes in the circulatory and neurological functioning may lead to not only female problems in the female, such as vaginal pain, Dr. Ambuja was mentioning quite a few times, also on the male partners in the form of erectile problems. Chronic illnesses, common medications, and emotional issues can influence sexual capabilities also. But the emotional byproducts of maturity, increased confidence, better communication skills, and lessened inhibitions can help create a richer, more nuanced, and ultimately satisfying sexual experience. And this is where I want to stop. Thank you, Dr. Maninder.
Thank you, Dr. Suraya, for summarizing each and every one speaker's ideas and the messages which they are giving. And even I'm realizing that all of us, I think, have to learn a lot from this webinar and from our panelists and all the specialists who are there. And you have very well said that physical transformation and physical change can be one of the main biological reasons. Then psychosexual reasons can also be there. So all these things, they have to be looked into. Now, Dr. Saroj Prasad, we are asking you again. Sonia, 65 years of age, menopause, 15 years. Since for 15 years, menopause comes to clinic with a history of burning, micturition, and itching. And when pointedly asked about sexual history, she admitted that she did not have desire for sex, but then she was not bothered. So would you treat her in these cases? So what is the incidence of any, if you know about desire and distress, same or it is different?
Okay, thank you very much once again, Dr. Maninder. As a gynecologist, I think this type of the patients come to you in your clinic or in your hospital, or as a psychiatrist also, one of the reasons they might come is because of decreased sexual desire. But sexual desire problems are widespread among aging women. Importance is whether they are distressed or not depends many factors. Very minimum people, they come to seek the treatments. The reason might be because of the stigma or because of the embarrassments associated with this. In this case, 65 years female. So the important part is we need to do a proper evaluation and make the proper diagnosis, because it might be caused, it is caused by the various physical disorder, maybe urinary tract infections or genital tract infections, or it may be because of 65 years hormonal changes because of that decreased sexual desire, maybe vaginal dryness because of the physiological changes. So in one hand, the another part might be some psychological factors like stresses, anxiety, relationship issues, which can also impact sexual desire. So it is crucial for all of us of each individual to seek the medical help, and they can take the medical help. We can conduct thorough history taking, including the sexual history, and make the diagnosis and accordingly make the management plan. So if the persons are in distress, I think they need some kind of the psychological interventions on the top of some medicines. If there is some physiological changes because of physiological changes, maybe may need of some estrogen cream, whatever. But the most important part, if the person is distressed, I think she needs psychological counseling also. Thank you.
Dr. Saroj Prasad, so the carry message is that maybe the women know that they are having a sexual desire, low sexual desire. Maybe they are not able to respond to their partners, or they have, but they don't feel distressed. Might be they are upset about other. As you said, we have to look into other causes why they are not distressed. So we should look into that. Otherwise, if the women are not distressed, they are not interested, then we should just treat the physical complaints with which they have come to us. So another question, Dr. Saleha.
Maninder, I want to add up that gives an interesting view that in many studies with the hypoactive desire disorders, in a younger age group, the incidence and prevalence is more because they're more distressed. Whereas if you see that she's a 65-year-old, so automatically she's not much bothered about her sexual functions. The problem is more about the physical. So that's why she's not distressed with the sexual problem. Though the prevalence and incidence is more in the higher age group, but their distress part is very less. So you don't need any much of a treatment.
Yes, that is true. I think I showed it one of the slides, but missed it.
Yeah.
That the younger women are more distressed. Younger desire disorder is more in the elderly, but they are not distressed. So that is the main part. Then we have to look into other physical or psychological problems. So Dr. Saleha Begum Chaudhary, does GSM affect sexual function in midlife? Just whether give evidence whether it affects or it does not affect.
That's a wonderful, nice webinar you have. A very thanks to you for opening up a lot of vision about the sexuality in the women in the menopausal age. And a very special thanks to SAFOMS for all this wonderful webinar with a lot of faculties here. I very much agree with you. When there is a GSM, that is a genitourinary system of menopause, they definitely have a lot of vulvovaginal atrophy because of the hypoestrogenic condition. So they have a lot of atrophy of the vagina as well as the vulva, which leads to very many problems, both urinary as well as the sexuality. So definitely they have a lot of problems in the penetration. They have a painful sexual dysfunction, as well as they have a difficulty in orgasm. Almost all the sexual functions gets affected because of the GSM. They have a lack of lubrication, they have a lack of desire, they have a lot of pain. Every component of these sexual functions gets affected. So definitely GSM will have an impact on their sexual functions.
So that's why they are reporting that without a partner, they reported that if they have that problem, they were not seeking a sexual partner because of these symptoms on.
You're right.
Yes. So now we come to, because we are running short of time, Dr. Harsha Patu. Vandana has osteoarthritis of knee and chronic back pain, and she has sleep disturbances and comes to you for help. Her husband talks to you in private about her libido loss. Are her chronic diseases of menopause interfering with sexual function? And what are her biopsychosocial factors which can interfere with the sexual function in the midlife menopause?
Thank you, Maninder, giving me this chance.
Interfere, the first question is.
Yeah. So in the menopause itself, it's a life event where every woman will undergo. So along with this, the disorders like hypertension, diabetes, depression, neurological diseases, urinary incontinence, osteoarthritis, which also come into play. So when somebody is having osteoporosis, you can't take it as isolation. So it is coming along with the, and we know that the one of the main reasons for somebody to have osteoporosis is lack of estrogen. So the other conditions like fatigue, exhaustion due to work, and the body aches, pains, and taking medications, then history of anxiety, losing loved ones when you are aging. So all these come into play when somebody is having osteoporosis. And one of the good examples I give for the patients who have osteoporosis is the way that the hippos have intercourse. That hippos mate in water, because the male is about a ton, weighing more than the female. So she will be suffocated, the female. So when you have something like osteoporosis, which you give pain when your joints are not working the way that you want. And so better to look for a way that you can circumvent, come around and find the sexual function little bit more enjoying. And people think that the penetrative sex is the sexual act. It is not so. It is there are so many other ways that someone can give the sexual pleasure to another person. And also the biggest sexual organ is not the things that we think, but it is the brain. So CVD and the sexual dysfunction. So cardiovascular disease impact women's sexual desire and also the arousal, and because it affects the systemic flow, as well as the thought that you have always in your mind that you are not normal as before, that you have a chronic disease. And the invariably somebody who is having CVD will have reduced physical function because she's scared to involve in the previous acts or whatever the exercise or whatever she has been doing. And we know definitely that chronic diseases like diabetes causes nerves and the vessels to get affected, so which has in turn an effect on the sexual function.
Thank you, Dr. Harsha Ataputu.
Yeah.
I have highlighted that there can be physical changes, there can be vascular changes, or there can be neurological changes which can affect the sexual function of the women, and they can have the low libido because of that, because they are not able to perform. Another question was from Dr. Saleha Begum. She's not here. So Angelina, 51 years, comes with history of fatigue, sleep disorders. She's on antidepressant and husband complains she has lost interest in sex. So can medications contributing to sexual disorder? Are medications contributing to sexual disorders? So what are these medications? Jaya, I think you will have to take.
Yeah. Yes. So almost all the medications given for the antidepressant, that is the depressants, definitely have an effect on the sexual functions, especially the mood stabilizers, SSRI, and your tricyclic antidepressants, and the MAO inhibitors, and antipsychotics, and even the cardiovascular drugs like antihypertensive, digoxins. Everything will have an impact on the sexual function. They cause a lot of effect through the hormonal as well as through the it has a direct effect on the neurotransmitters, and thereby it has a suppression of the sexual functions. Along with that, it has a lot of effect on the locally. It can also cause a dryness, which also can add on to the sexual dysfunctions. So very importantly, the drugs has a very great impact on vaginal dryness also, which may also lead to the dysfunction in this women because of the chronic, because of the drugs which has been given for the chronic problems.
So thank you, Dr. Jayarani, because now you have highlighted whenever women come with any sexual dysfunction, the drugs which they are taking should be taken into account, especially antidepressant, because we are giving them drugs for depression, and if they are not able to do sexual function, then that increases their dysfunction again. So
Yeah.
Not only antidepressants, but most of the people at that age, they have the diabetes and hypertension. These drugs also has got so much of effect.
Yeah.
Forget about antidepressants, which everybody will not take. But 1 in 3 at least, they are hypertensives or diabetics. These drugs, prolonged taking all these things, definitely there's got a bad effect. That is very much essential.
That the diseases and the drugs, they both affect the sexual function, and we have to draw a line somewhere in between for these people to help them perhaps change the salts or help them with the physical exercises and quality of life issues. They have to be changed, because if the quality of life is not there because of some physical problems, again the sexual function will be not there. So it's a sort of vicious circle which is set up for them. Dr. Jaya, 52 years of female enters your clinic tired, exhausted, and discusses with you her interest in life. And when you discuss with her about sex life, she shares completely no sex for 6 months. How you screen her and identify her problem? Now comes the patient to us.
Yeah.
You have to screen her.
Yeah, that is very important that when we are looking into this women, we have to find out the cost, because we know pretty well that she's distressed more than 6 months. She has a definite hypoactive desire disorder. So very important is we have to find out the cost. We have to find how much she is affected and how we have to evaluate her. Everything is concentrating on the management part, which is very important. So any desire disorder have 4 important basics. So very important, you have to ask for a detailed history, when it started, how it started, was it started with a partner relationship or following any chronic debilitating illness, or after any therapy or treatment that she had, or following any other psychological distress or a relationship disorders within the husband. So all the history and details about how its onset, progression, as well as her causative factors and the chronic debilitating illness which she has, either the diabetes, hypertension, everything has to be checked. And the drugs what she's taking also play a very important role. And then of course, when she attains the menopause, and the menopausal symptoms also can add on to it. So this will make her categorized into the 4 important causes for this hypoactive desire disorder, like mainly the chronic debilitating illness, and second the drugs, and third is the hormones, and fourth is the relationship. So all these 4 categories has to be kept in mind when we are taking a detailed history in these women. That will make us go through what could be the causative factor, and depending on the cause, we can plan the treatment for her. And definitely we have to make a complete thorough examination. We have to examine her locally. We have to examine her psychological status. We have to examine her with all the questionnaires so that she can give us exactly how much is the effect, it has the effect on her personal life. That is very important. We have to ask about the FSSI index scoring. That will give us exactly how much is the problem that she's suffering. So very important, we have to make every part of the history, clinical examination, and all the past, every details has to be checked. And local examination and the general examination is very important. And we have to take the distress scoring, which is a 5 questionnaire, in which I think that questionnaire you have to have it. That's the distress HSDD screener, which is the desire disorder distress scoring system, where if the first 4 answer of the first 4 is no, then she don't have the problem. And if she says an S, then we have to go for all the causes, which is included in this distress scoring system, which will exactly give the cause as well as the effect of the problem, so that will help us for planning the management for this women. So very important is the HSDD scorer, that is the distress screening, distress decreased desire screener, which is a very important screener, which is very helpful for find out the cause as well as to plan the treatment.
Thank you, Dr. Jayarani, because you have highlighted, we have to know whether it is acquired or it was there previously only. So then only we can plan the treatment for her depending upon the cause which we find. So these screening modalities are going to help us in proper diagnosis of the conditions, whether they are situational or acquired or they have been there for a lifelong. So treatment will depend upon that then. Yes, management part, initial
management should be the psychological counseling, which forms a very important one. And then we can add on 3 important therapy. One is the CBT therapy, cognitive behavioral therapy. And second is the couple therapy, which is sensate focus therapy, which will help them to relieve this, get the problem corrected. And very rarely we have to go for a pharmacological therapy, especially when a woman at 62, there is always less chance with any treatment for the desire disorder. We can give them local treatment to improve the vaginal lubrication, which will help them to improve in their sexual functions. So
I think Dr. Saroj also had highlighted that how these things are important to therapies, various therapies. He has already pointed out couple therapies and all those therapies are there, which we have to learn about, and the proper counseling and identification. Now, Dr. Ambuja, will you in short tell us about the physical examination, what we are going to look into? Now we have...
See, almost everything is covered by the Jaya. Not much to add, just I want to add two things. Never, especially countries like ours, little, when we should never forget about the tuberculosis, anemia, and hypothyroidism. These three are very important things. Just you see the patient, whether she has got any other ailments like osteoarthritis or obesity, all these things, they play a part. After examination from top to bottom, then we have to go for the local examination, which is very important. Atrophy of the vagina, clitoris, or whether there are any secretions present or not. This itself makes us to say this is the reason for the hypodesired sexual dysfunction. And second is the thing is do a speculum examinations to see whether there are any erosions on the cervix or whether there are any growths in the vagina and cervix, because polyposis, vaginal polyposis and cervical polyposis are more common at this stage. With all these things, I think I already spoke about the probiotic deficiency in lactobacillus deficiency that can be present because of the estrogens that are lacking in the patient. And second thing is, even when the estrogens are lacking, without any involvement of the bacterial vaginosis or anything, there will be false building discharge. That we should always think of it. Sometimes cervical stenosis may be one of the causes, and sometimes the pathogens also will add. And this differs from patient to patient. Not everybody will suffer with this. That's a question that comes to our mind. Sometimes even a 60 years person also will not be suffering, but sometimes 45 years also will be suffering. Why it is happening? The science has come out saying that the ecosystem that is there from the anus, sometimes it supplies the bacteria, the good bacteria, and so the vaginal ecosystem will be maintained. So it is still not proved, but that is one of the reasons that is there. And a lot is talked about the probiotics and prebiotics at this stage. Maybe that is the one which is going to help. Why I'm telling you so many times, all of us have got the experience. Patient coming with a false building discharge or anything, we do give them metronidazole, clindamycin, and vaginal tablets. It gets cured for about a month. Again, she comes back. 3-4 times if she is not happy with us, and she will change the doctor. That happens. Why it happens? It is the temporary treatment with all this that happen. But once you give the prebiotics or the probiotics, most of the times, the time will be prolonged for 6 months.
Yeah, Dr. Ahuja, so main issue was that whether the examinations are important and how we should be doing. So first we have to do the general physical examination to find out if there are any general physical conditions. Then we should go to the local, whether they are the vaginal atrophy symptoms or there is some other pathologies also which can be there. So we should look into all those pathologies when these women are coming to us. Professor Shaheen Zafar, Sita Rani, 48 years, comes with vasomotor symptom, loss of libido, lethargy. Any role of biochemical tests? It's just a question.
Yeah, okay. Maninder, in the interest of time, I'm going to be very short.
Yeah, time is short now.
This case is a very clearly a perimenopausal woman with the menopausal symptoms. So we can confidently start her on MHT or whatever, but still, having said that, we must exclude thyroid, hypothyroidism, and anemia, and tuberculosis, because these are common things in our society, and we must exclude them, and we can start treatment for menopausal symptoms.
Shaheen Zafar, really very good answer. That is these are the 3 things which we should be looking into. Yeah, Rani, can you please quickly tell us what is the initially counseling? What is
the initial counseling is best is the Blizzard model, which is the first model offered for introducing sex into a clinical conversation, narrowing the scope of the women or the patient concerned, and offer an effective counseling. The initial part is very important. That will help her to start the thing. So we have to put a leading question, ask her a permission. Do you have any sexual problem? If you put the question, she will come into the answer, because sometimes they may be very hesitant to start the conversation. To start the conversation, the Blizzard model is the best one to give her permission and a lead so that she will be opening out questions. And then you have to give about a limited information about what is a problem like, what are the basic function, what is it different, all those things you can talk into her and give her some specific suggestion. Third one, in the form of some advices and directions and treatment. And then of course the intensive treatment, you can refer them to any sex therapist or individual therapy or a CBT. So this split model is the important model which we have to keep using in our clinical practice when you come across any women with a sexual dysfunction. This forms a basic initial opening up of the women for this problem and giving her the good best counseling and the treatment. So that is where it plays a very important role.
Thank you.
Yeah.
Thank you very much. That agreeing that implicit model is the very, very basic, which we all of us should be looking into. Now, Dr. Harsha Haththotuwa, can you briefly tell us role of hormones in sexual desires?
Yes, if you take in short, the three hormones that are involved in the sexual activity is the estrogen, the progesterone, and the testosterone. The long thought, the hormone which was coming into play in female was testosterone. But contrary to that, now the more and more evidence is coming, it is still the estrogen which plays the major role with regard to the sexual function of the woman. So basically, estrogen is the Eve, or is the woman who keeps the sexual function, desire, and her body contour and her well-being in proper place. So estrogen can be delivered in various ways, by tablets, pessaries, sprays, or the vaginal gels. So which is used in various modalities in sexual dysfunction. For instance, for vaginal dryness, you can use gels and the sprays or things like that. Or if it is not the general well-being which is affecting the sexual function, so it is more likely that you will move more towards the oral treatment. So this is an example that of a new product, which is Lenzetto, is a vaginal spray that contains estrogen. So more and more scientists, doctors, and even the drug pharmaceutical companies are addressing the issue of female sexual dysfunction, because now more and more people now understand the importance of the sexual dysfunction and the remedies for that. So I think that would give you a short answer. Because of the time, I'm going to stop it there.
So basic thing is that normally menopause hormone therapy doesn't have a role unless the patients come to us with the menopausal symptoms like vasomotor symptoms and all that. So if they are distressed because of them, then we give them that. But sometimes when we are giving, they are not improving, and then we have to give the androgens to them. And various androgens are available, like oral tablets, and the vaginal tablets are also available. Now, what has come improvement is this is the transdermal. This is available in India now. I don't know whether it's available in Sri Lanka.
No, it is not.
It's not available. So Lenzetto is available here, and this causes improvement not only in hot flushes, sleep disorder, but also vaginal dryness also. And this is just a transdermal spray, so very easy to give. And 1.5 milligram of estradiol is given. So this can relieve, I think, the symptoms of another thing which I come across literature is the vaginal tamoxifen. So this can be given in patients of the cancer survivors where they have the problem. So they say it is improving the libido also. So that is, I have read in the literature. And of course, the other drug is the Tibolan, which can be tried to improve the libido. And DHEA hormone supplements, especially for the cancer survivors. And then if the patient had the hysterectomy with self-injectomy, they no desire to role of testosterone is there. When we have treated other symptoms, local and everything, then we can give the testosterone in titrated doses. So because we are running short of time, So that's why I had to take this question quickly, because we'll be again discussing the genitourinary syndrome in one of our incoming webinars. So at that time, we'll discuss in details about everything. So women who undergo surgical menopause have 50% decrease in serum testosterone, and in them 300 microgram transdermal testosterone can be given. It is available for infertility patients, so we can use them, but the physiological levels should not exceed in these cases, because then they can have side effects on lipids, hair growth, and it takes time to have the effects. So now, last question for the—
Dr. Maninder, just one thing I want to add here, just only one thing. You have covered all the hormones, but what about the ospemifene? It has a very good role in sexuality.
Has already been discussed by one of the speakers. So I am telling you that we will be taking this topic in details. Genitourinary syndrome of menopause. And one webinar actually for this genitourinary syndrome of menopause, because we have to discuss in details. So that's why I am taking here quickly that whenever needed, whenever there is a need, which most of the times is there, then depending upon the need of the patient, we should give the treatment. And ospemifene and every drugs are, of course,
and testosterone. Okay, thank you very much.
Testosterons are important. That's why I said, told the doses even. And Professor Rohana Gul now, non-hormonal treatments in sexual dysfunction, because these are very—
Thank you so much. In a non-hormonal, I would just go quick. Filbenserine is actually called the pink Viagra. It is FDA approved, and people can use it. The dose is 100 milligrams once a day at bedtime, and it should be used minimum 4 weeks to see the results, whether it is working or no. The clitoris vacuum therapy, it's a very good thing that you give it to the patient and they can use it. That's the only thing that when you use the vacuum, what it does, it is improve the blood supply to the clitoris, and it increases the blood supply. And with the blood supply, if it increases, there are obviously more, because the sexual functions in every talk that we did at the end, I would say, is the clitoris that make you orgasm and that make you actually feel the sex. So the clitoris has to be a healthy one. Very important, I'm ending my non-hormonal with that aesthetic has taken place of your face, of your body, and everything. And this is the new word. So aesthetic has taken place in your vaginal health as well. We have tried in Pakistan, I'm doing all the vaginal PRPs and vaginal lasers as well. And trust me, it has very good results. Vaginal PRP, we just take the blood, make the PRP, inject it inside the clitoris and inside the G-spot. You have explained it to the patient, because with the time, the body changes and the body actually loses the clitoris and the G-spot especially. With age, the G-spot is gone somewhere. So you have to actually inject the PRP inside the G-spot, surrounding the vagina, and also in the clitoris as well. It works very good for at least 1 year to 18 months. Normally in a face and a hair, you have to repeat the sessions after every 6 months, but the vaginal PRP is only once, and if it works for 18 months. Very reasonable procedure. Same goes for the laser therapy. Laser therapy, we have different sessions, and these are the sessions that you take. What it does is regeneration. So basically, these are the regenerations of vagina, and that's it. I think aesthetic has taken place. So I would actually vote for the aesthetic vaginal PRP and vaginal regeneration.
Rohana, very good, because the incoming therapies now, which we are becoming popular, I think in all the countries, are the vaginal PRP, laser and RF treatment, which are there, which are increasing the blood supply of the vagina and the musculature also. So that is where they are helping us. And of course, the Eros cup, which is available, clitoral stimulation.
Yeah, as I mentioned, the basic queen is basically the clitoris. So we have to keep the clitoris healthy. In every talk of ours, at the end of the day, whatever we are doing increased blood flow to the clitoris. We are making the regeneration of the clitoris and all that. If the clitoris is healthy, there is going to be a healthy sexual life.
What about filbenserine? It is available, because I think it is available in India.
It is not available in Pakistan. Yes, it is, but only few pharma can provide it to you, and it's quite expensive. So filbenserine is actually a pink Viagra. In Pakistan, when the patient complains a lot with DHEA, I prescribe the blue Viagra as well as the male one. So it works as same, but filbenserine is an expensive drug over here right now.
So now we come to a very important question that is upon Dr. Zinnat's talk. So role of estrogen in cardioprotection, how they are helping in cardioprotection. Dr. Begum, but she's not here. So estrogen is cardioprotector. Ahuja, you are there. So estrogens, as Zinnat has already highlighted, that it has a positive effect on endothelial function, vascular tone, cardiac function, and it makes the blood vessels flexible and decreases the peripheral resistance. Basically, very important is that TNF alpha increase the prostacyclin 2, which reduces oxidative stress is reduced and platelet activation. And it increases the production of apolipoprotein A1 and decrease in hepatic lipase activity and facilitates increase of HDL-C therapy, thereby it acts as a cardioprotective. So actually estrogens have been known to increase the HDL and especially the transdermal route decreases the triglycerides also and increases the LDL. So that way decreases the LDL. So that way it helps in the cardioprotection. Then contraindication to menopause hormone therapy. I think Dr. Sleham has some meeting with the government of Bangladesh. That's why she could not make it. So contraindication to menopause hormone therapy are pulmonary embolism, DVT, angina, MI, past and present history of breast cancer, active liver disease, porphyria, undiagnosed PV bleeding, untreated endometrial hyperplasia, uncontrolled hypertension, and recent stroke. So all these, when we have been talking about menopause hormone therapy, these are the contraindications we cannot give. So now key points are that sexual dysfunction increases with age and is highly prevalent. Most menopausal women consider sex to be an important part, but the women disclose their concern to healthcare providers. They don't disclose. So we healthcare providers had to take an initiative to start discussing with them. And when we talk about the treatments, the biopsychosocial approach to evaluating and treating patients with HSDD is recommended because it's a multifactorial problem. Now we have seen it's not just the desire, but these can be related to your physical problems, various diseases, various medications. So you have to go through a simple algorithm, implicit model, and then invite them. Then you can give them the counseling or filbenserine, which is very, very effective in HSDD, and other medication like transdermal testosterone, bupropion, bremelanotide, melanocortin receptor agonist is in the last stage clinical development. So they will be available for the future patient. The main thing is that we have to learn. We have to go still a very long way to learn about all these things so that we can help these women with the silent epidemic or pandemic of the sexual problems which are there. So we invite all of you to Menopause, Pakistan Menopause Society conference on the 18th to 19th November at Marriott Hotel, Islamabad. Please let's plan and be there in large numbers to attend that conference. Thank you very much. We have learned a lot, but we know that there is a lot more to be learned, which we could achieve very less in this 1 hour webinar. I think we took a little more, but thank you to all of you for being here. And thank you to
Maninder, there are 2 questions in the question box.
Yeah. Oh, questions. So there were lots of
there
them.
are two questions only.
Yes. I have to stop sharing.
Only 2 questions.
Stop share. Yes, I'll see. Chat box. There were lots of chat box questions. Wonderful talk by Zinnat.
Maninder, question box, there are 2 questions. In the chat box, no questions.
Okay.
Only 1.
always helping us physicians to open taboo topic with the patients in the right way. Professor Arifa Bari, in our part, the women report only the pain part of sexual response. Fabulous deliberations. This is the question answer, no?
No,
No, Maninder.
you can go to the question.
Other chat
Question.
box, it is there. Women reach menopause, unfortunately.
Yeah,
due to
these
late
are the
marriage.
questions. Can postpone menopause and what are its advantages and disadvantages?
Yeah,
Doctor?
we can do by ovarian rejuvenation, we can do a postponement of the menopause.
Okay, for future. Yeah.
Ovarian rejuvenation we can do with PRP that may help to improve the menopausal age, so that will help her for a better, delaying the menopause. And that is a very important latest way that we do for the fertility as well as for the postponement of the menopause.
I think menopausal sexuality issues are very, very important for Pakistan because all these questions have come from Pakistan only. And after 5 years of menopause, can we reverse it? We are still in the experimental ages, going to the stem cells, which we can find in the ovaries and in other places where we can rejuvenate the ovaries, or sometimes we can replant the ovaries, but still clinically nothing is available. Asif Rahim Malik, a woman has reached menopause, unfortunately, due to late marriage or heavy, her family is incomplete. Can we reverse the menopause? So all the questions are on reversing the menopause, how to help a patient who claims she has low sexual desire, but in history, no reason can be found and she is seeking some medicine necessarily. Of course, there has to be some reason. The only thing is we are not able to diagnose, then we have to refer them to the specialists who are dealing with the sexuality problems. There are few and far between. So basically now the psychiatrists are only one who are treating. So we as gynecologists also have to learn these things, because then if we go into the history, complete physical examination, that is why I have given so many of the questionnaire format which we have to learn so that we can help these patients. And Dr. Kusum Bandara, do you think the prevalence are true representations? It is only a tip of iceberg, isn't it? Of course, it is a tip of iceberg. I think all of us have realized that. Don't you agree? Dr. Zinnat, Dr. Saida Batul Mazar, don't you realize?
Can I comment? Can I give a comment?
Yes.
It's Dr. Saida Batul from Pakistan. I think it was a fantastic webinar, and the conclusion of all this session is that still there is tremendous reluctance of the doctors and the patients to talk about it. That remains a problem. So I think that problem has to be accepted, and that's only that we can move on. And I would like to reiterate and invite all our colleagues from all the countries of SAFOMS. Please note the dates of our seminar and conference that we are going to hold in November. And if you have any, we'll be sharing all the details in a couple of weeks. And then we'll be looking forward to some of our colleagues visiting our beautiful city of Islamabad, from Nepal, from Sri Lanka, from India, and whatever invitations, and Bangladesh, and obviously all our member societies. Thank you, Maninder.
Thank you, Saida. And as I said at the beginning of my introduction was that we are having lots of problems, untold issues, undiscussed issues, and the healthcare providers are not discussing. So, but with so many people involved and bringing the message together, and we will be having more and more thought processes and more discussions now on the sexuality issues, because we have to bring this issue out of the cupboard. It was like, don't discuss sort of a thing, which I think we have removed that taboo, and we will be going forward. My heartfelt thanks to our speakers, Zinnat Nasreen, who is a close friend and a dear one, always comes to help, and Professor Arifa Bari for their wonderful presentations and making the subject so easy to understand, at least start the understanding of the subjects and highlighting that these subjects need our attention as menopause specialists, and repeatedly these younger generation telling us that we have to go for more of our own data collection and more our research methodology, what our women need differently from the Western women. And our panelists, Professor Sahin Zafar, Professor Harsha Ataputu, Jaya, our Rohana Gul, Ambuja, all these panelists who were there, Dr. Brigadier Suraya Rahman, to top it all when she was not well and still she was here, and our chairpersons, Rubina, Hussain, Narendra, Malhotra, Hemantha, being the sharing their pulse of wisdom, and not the least, our partners, Dr. Deepika, who is all Deepika Chabada, she is, and she's always there. I just have to give a call that yes, I have to do this webinar on this date, and she will be there. So next webinar we will be having on 10th of August. Please note the date, and we will discuss which topic we should be discussing, whether it should be musculoskeletal disorders, because I think that needs discussions. And after that, we will be taking again then bladder problems, and then the vaginal issues, because I have separated them because these issues matter a lot. So thank you to all this, and I hand over to Deepika. And these are our future, which she has already sent us. Joint and muscular problems, bladder problems, dryness of vagina and burning in the vagina. And then risk assessment tools will be taken in the last. Menopausal risk assessment tools are very, very important for compressing the comorbidities and for preventing the problems of the menopause, because there are lots more than the vasomotor symptoms. Deepika, to you. Yes, anyone to comment, please? These are the webinars which I have already held in the past. So the first one was the metabolic syndrome, then hot flushes, then sleep disturbances, and now we are having the sexuality problems and the heart problems. Deepika, to you. Thank you to Jagsonpal for giving their complete support to us. Should we say
Thank you very much
right now?
Right. So before we end, just a look at our a few of our products which could be of use for your menopausal patients. This is LycoRed, the ultimate cell protector, which has lycopene along with its phytonutrients as available in natural tomato. This LycoRed has lots of studies. We have 35 clinical trials with it and many publications in very many indications. The lycopene that we have is actually an exclusive patent protected product called Lycomato, which contains not only lycopene, also vitamin E, beta carotene, phytofluins, and phytoins, phospholipids, and also phytosterols. Besides this Lycomato complex, our LycoRed also has zinc and selenium. So a total that can also, the LycoRed is available in a sugar-free syrup formulation. This is safe for diabetics. For vaginal infections and vaginal dryness, you can always try out our Verena Nano Silver Vaginal Gel, which is available with the applicator for internal application, and also external application is required. So even for menopausal women, non-infectious vaginitis, this would be of use. And Divatrone in case there is a requirement to prescribe progesterone to these menopausal women for MHT. So that's all we have for, thank you so very much.